Wednesday, April 29th. So let me just open the floor. Maybe we could talk about any questions you might have with regard to lab stuff. Do you have any questions on lab stuff? We had exercises 37 and 38 scheduled for this week, which was blood cells and typing and heart structure. Then we talked a lot about kind of what to be looking for in those exercises on Monday.
Mm-hmm.
Have you had a chance to look at the YouTube videos that I posted?
Of your lectures or for the lab?
For the lab.
I haven't looked at the YouTube videos for the lab yet, but.
Okay, you should do that soon.
Mm-hmm.
Because there is one there that talks about blood typing, which is often the topic that sometimes confuses students. But I thought that video did a fine job with that. Anybody questions? Melissa, you popped up a second ago.
Yeah, I'm still kind of confused on the blood typing. I did watch the video once. I need to watch it again, but I don't know. And I didn't really know how to fill in the lab in the book. Like, can we fill that in? Or
specifically, what are you referring to?
For the blood, the lab 37.
Yeah.
The chart or whatever. Are we able to fill that in, or
give me a page so I know exactly what you're referring to.
I'm trying to find it.
Exercise 37.
288. The part C assessment.
288. Oh, part C assessment. That's white blood cells. Is that what you're talking about? A or C1?
Yeah. Yeah.
Yeah, you can't do that because you don't have a sample to look at.
Yeah.
So no, you cannot do that. Theoretically, what you would have done is, let's see, they would have looks like they had you let's see. In the lab exercise, they would have had you probably look at a slide. Yeah, you would have looked at a prepared blood smear slide. And then the idea was behind that is you would look at the diagrams there that differentiate the 5 types of white cells, and you would have looked for like the presence or absence of granules. You would have looked for the shape of the nucleus. In other words, you would have got good as time went on at, seeing a neutrophil, knowing what it was, seeing a basophil, knowing what it was. And then you would keep track. You have to scour the slide in a particular way so you don't double count a cell. But the idea is if you counted enough cells and kept track of each, which is what that little table is, you would be able to get numbers, percentages that are typical of a differential white cell count. That's all that was. And I told you the other day that I'm not going to ask you to differentiate a monocyte from a basophil from an eosinophil. But if you're a clinician or you're into hematology, you get pretty good pretty quick at differentiating. Once you've seen 1 million cells, you can know, yep, that's what that is.
Okay.
Yeah, that's all that was. I think the Part D assessment questions just below that would be good to answer as you learn about the blood typing. You know, as I said, those answers are in the core shell, right? The answers to all of these lab report questions. And so those would be very, very good to do. And you may need to watch that blood typing video a couple of times. You know, just because it didn't make sense the first time doesn't mean you shouldn't watch it 2 or 3 more times.
Yeah, and I watched it like last week or something, so I figured I would watch it again, but
Absolutely, you should watch it a couple times. In essence, it's really not that difficult if you remember that the name of the blood type, like say A, is due to the presence of A antigen on the surface of the cell. So these antigens that they talk about are proteins, and they're membrane proteins. If you had, excuse me, if you had type B blood, then you'd have B antigen on your red blood cell membranes.
okay.
If you had AB, you'd have both, A and B. If you had O, you have neither A or B antigen on your red blood cell membrane.
Yeah.
In addition to the antigens, you have to understand also about the antibodies, which are circulating in the plasma. And again, the video will talk about that.
Okay.
The other thing that I think I mentioned on Monday was you should go into the blood chapter and reference that section on blood typing. Remember us talking about that?
Yeah.
550. Yeah, I mean, you should study that after you watch the video or before you watch the video. That's a very, very good section. It talks about the presence of the antibody in the plasma, the antigen on the surface of the cell. Yeah, so definitely, absolutely check out that section of chapter 14. Misty, question?
No.
Okay, you popped up. I thought maybe you were going to say something.
No, my dog was talking.
Your dog was talking. Okay. What does he know today? Does he know anything about blood typing?
I mean, maybe.
Okay. So any questions on 3738 lab stuff? Okay, how about cardiovascular system questions? Chapter 15, which we're doing this week. I posted the last voiceover PowerPoint about an hour ago. So that chapter is done as far as me narrating the slides. So by the end of this week, the goal is that you should have looked at those. I don't know if there's 3 voiceovers. I forget the exact number, but they're in that folder. And then starting next week, and then that following Monday, our last class day, we're going to be doing the lymphatic system and immunity chapter, which is 16. Doesn't mean we can't talk about 15, of course, next week as well, but I'll be starting the voiceover PowerPoints on that chapter, soon. I hope you're looking at those because, I'm putting lots of time into making them, and you should be watching them and then following with the book, reading the text. Yeah. Any questions on heart structure? That was kind of the first part of the chapter.
I kind of was looking, well, I was watching one of the videos, I think it was this morning or sometime yesterday, and it was talking about the fossa ovale and the ligament anteriosum.
Yeah.
Are those things that we need to have memorized?
No. Probably I should talk about that, but there comes a point in time where you have to draw the line. So you do not need to know about the ligamentum arteriosum. I can tell you what it is. It's very interesting. This is really addressed more in a chapter you'll be covering next semester in A&P2, which is the Pregnancy Growth and Development chapter 23. Because if you look at fetal circulation, and I'm trying to remember what page exactly this is on. It's on page 889. In the fetal circulatory system, there's a connection because the lungs aren't functional.
Yeah.
Okay, and the baby's getting its oxygen from mom via the placenta. There is in a fetus, and we'll the chapter here. Fetus. There's a connection between the pulmonary trunk and the aorta. Okay, and when the baby takes its first breath, one of the things that happens is that connection basically sort of closes up, for lack of a better way to describe it. Because then when the baby takes his first breath, we assume the lungs are functional at that point, and you don't want to be mixing blood, entering the pulmonary circuit heading to the lungs with blood that's coming out of the left ventricle having been oxygenated by the lungs. So that ligamentum arteriosum that you see on page 567, it's not labeled, but it's a little white cord. If you guys look up here, you can kind of see this little white cord-like structure?
Yeah.
Yeah, that is the remnant of the connection that you had when you were a fetus. And so if you looked at a human heart, an adult cadaver, you'd see that little bitty ligamentum arteriosum connection there. Isn't that cool?
Mm-hmm.
Yeah. And the other thing that's really neat is, and I would hope that you guys would talk about this when you get to the pregnancy chapter. There's also a connection that you alluded to a few moments ago. Go back to that page. The foramen ovale, that is a connection between the right atrium and the left atrium. Because in you and I, we don't have that. But in a fetus, there's a connection between those two atria. Isn't that cool? And that, in turn, basically closes off about the time the baby is taking his first breath, its first breath. Yeah. And so we have in our hearts this little remnant structure, if you were to go and look. Sometimes babies are born with these defects that haven't closed, and they got to go in and they got to operate on the baby. Because if they don't, the outcome is very poor. Can you imagine operating on the heart of a 3-month-old? Holy moly, that's, heart's little.
Yeah.
Plus, you got this little baby. My gosh, so but every day there's surgeries done, and with good outcomes. We've learned a lot about that over the last. Cardiac surgery really came on its own back in the 1950s. Prior to the 1950s, the heart was this organ we just couldn't get to, and if we tried to get to it, patients died. We didn't know anything about maintaining blood pressure. We didn't understand the connection between the pulmonary system and the cardiovascular system, and a lot of things we didn't understand. But it was basically after World War II, when the GIs came back with all these heart injuries, like shrapnel wounds, that heart surgery really took off, cardiac surgery took off. And that's not that many years ago. I mean, it seems like a long time ago, but 80 years ago, 70 years ago. Prior to that time, man, nothing you could do.
Wow.
Yeah. There used to be a series on Nova, which is a PBS show. And the series that I remember watching back in the late 80s, early 90s You probably can Google it and find it. And if you can, it's really good. It's called The Pioneers of Surgery. And it takes you through all different kinds of surgery, including cardiovascular, heart surgery. And it's really interesting. It's like, I think it's like 4 episodes. Really cool. So there's a long answer to your short question, Melissa. No, you don't have to know it, but isn't that interesting anyway?
Yeah.
How about any other things that are giving you grief in cardiovascular? Cardiac conduction system?
I guess I have a question. The precapillary sphincters.
Yeah. Mhm.
What do they actually do? I guess I kind of get it, but I feel like I'm not visualizing it the way that it's accurately.
Okay.
Like I'm
let's-
thinking like of a muscle to like contract, but that's kind of what they are, but not really, I'd have to assume.
Okay, let's take a look. Do you, let's see, I don't want this one. I want, let me pull up the PowerPoint. Bear with me here. I got to get out of this. I'm just going to the PowerPoint here of chapter 15. Okay, I'm going to stop sharing and I'm going to reshare, and hopefully you see the PowerPoint. Yes? Do you see the pacemaker here?
Yeah.
Okay.
Yes.
Oh, and by the way, I have a couple of these at school that I would have passed around for you guys to look at. This is what takes over if the SA node becomes damaged in somebody. You've heard of somebody getting a pacemaker put in, right? So this is a very small device, and it doesn't show you quite as nicely as I wish they would, how thin that is. That thing is probably a ½ inch thick. It's really thin. And it's about 2 inches from top to bottom. They've gotten smaller and smaller as the technology has improved. And so what they do is they implant this device just under the skin. I can remember looking at a cadaver years ago, and you could see the bump on the guy's chest just above the sternum where the pacemaker was under his skin.
Mm-hmm.
Yeah.
Yeah.
And then they
I've seen that too.
have you? Uh-huh.
Yep. I'm a living person, obviously, but
Okay, yeah. Uh-huh. And there's a couple of leads that come out of the top of this pacemaker, and somehow they will take, and I have one of those at school that I would have showed you. I'm really bummed out. I can't show you all this stuff.
I know, me too.
Yeah. Well, next semester, come see me.
Okay.
It's this kind of, it's this wire that you can see through a rubberized plastic coating. It's the best way I can describe it. It's very flexible. And somehow they are able to take that, stick the one end in the pacemaker, and then on the other end, they wire it through the blood vessels, I think, and they somehow attach it to near the SA node. And if the person is having issues, this device can somehow monitor that and deliver a little zap to reinstall, if you will, the normal sinus rhythm, the PQRST waves.
Yeah.
They also
My
have another device that is a little bit bigger, although again, in recent years, they've gotten smaller and smaller. And this is a pacemaker / defibrillator. So same basic idea, implanted under the skin, wire going to the heart. But if you go into the defibrillation that I talked about in one of the earlier voiceovers, where the ECG is kind of like doing this, it's just like all over the place, like spaghetti. Then, you know, normally if you're at the hospital and this happens, they take the pads and they put the goop on it and they'd say clear, and the people would stand back and kaboom, right, zap the guy. Well, this defibrillator unit will deliver a zap, if you will, to the person. Now, I can imagine if you're walking down the street and this happens, you know, what kind of a shock you're going to get. Of course, you'd probably be on the ground before it would shock you. I don't know. But it's got to give you a pretty good jolt.
It's actually not as crazy as it seems like it would be. So my grandfather, he had at like 68, he had a heart attack and had to get a pacemaker put in. And then a couple years before he passed away, he was like 80 and had to have it replaced and had the defibrillator added to it.
Okay.
And so his cardiologist used to like track, like she would see like his rhythm like in her office.
Yeah.
And it would, like you said, shock it back, and like he would go in for his yearly or whatever, and she'd be like, oh, you know, it shocked you back 7 times this year. And he'd be like, I never knew any better.
Okay. So it's more subtle than I envisioned.
Yeah. I mean, maybe it's different for different people, but he said he never really realized that it was different.
Okay. All right. Well, it's coming from the horse's mouth, so I believe you're right. Yeah. That's very interesting.
Yeah.
How long did your grandfather live after he had the units put in? Do you know?
Well, so when he was 68, he had a heart attack, and he went to hospitals in Buffalo, and they were like, you know, he's 68, like we don't really have the technology, he's high risk, this and this. So my family sent him to the hospital, Cleveland Clinic. They're
Yeah.
like the heart hospital in the world. So he went there and got they replaced his, like put a pacemaker in, and he lived for another 20 years afterwards. And then when he got it replaced with the pacemaker defibrillator, he probably lived for like 3 more years. But I mean, he passed away at 83. He had heart disease and whatnot and was overweight, et cetera, et cetera. So I mean, eventually it was going to be his demise. His heart ended up giving out, and that's how he passed. But the use of that technology gave him an extra 23 years or whatever. So
That's great.
yeah.
Yeah, and had he lived a century prior, like I said, he
Yeah.
probably wouldn't have lived as long.
Yeah, like even his parents would have never dreamed of having surgeries like that. So it's crazy, like when you think about it that way, that it really wasn't that far off.
No. And don't you wonder, like when you get older, or when your kids are your grandparents' age, what will it be like then?
Yeah.
Gosh, it's just
There's a show on, I think it's Netflix. It's something about like the AI, artificial intelligence, and how like they assume that by the time like our kids are older and like our grandparents' age and whatnot, that it'll be more we'll be more technology based than human when all said and done. So that's an interesting show.
Yeah, right. But how can technology overcome the need for a unit called the heart that pumps the blood? But,
Yeah.
But maybe something will be invented. You're right. It's like Abraham Lincoln sure didn't know anything about jets, and here we are flying all over the world. And
Yeah.
somebody had suggested that. So it's just, you just never know. Yeah, right. Very interesting. Well, here's that slide. And what it depicts is, and I like this slide for a number of reasons, not the least of which is it shows all of the 5 blood vessel types. Okay, so you have the artery. Is everybody, you're seeing that?
Yeah.
Okay, so the artery, which remember is defined as a blood vessel that carries blood away from the heart, and usually it's carrying oxygen-rich blood. Of course, what's the exception to the rule? Which artery isn't? Anybody?
Pulmonary?
Pulmonary artery, right. That's taking blood to the lungs from the right ventricle, from the pulmonary trunk, right? So that's oxygen poor blood that needs to be oxygenated. So that's the only exception to the rule. All other arteries are carrying oxygen-rich blood, which we depict here in red. Blue, obviously, is oxygen poor blood, And most of the time, veins which are carrying that blood back toward the heart are carrying oxygen-poor blood. The exception to the rule are the 4 pulmonary veins coming from the lungs to the heart. They have just received, they're carrying the most oxygenated blood there is, the 4 pulmonary veins, 2 from each lung. So we see the transition from an artery to an arteriole, which is just a smaller diameter blood vessel. A lot of the anatomy is very similar to the artery with respect to the 3 layers, which you should have learned about in this chapter. And then before we get to the actual capillaries, which is where we transition from red to blue, so we have kind of like a purple color, which is in between red and blue, right? This is where the gas exchange is taking place. This is where the nutrient waste product is taking place. This is where the red blood cells pass through in single file. That gives you an idea of how thin the capillary wall is here. And the lumen. This is basically just simple squamous making up the endothelium. There is no middle or outer tunics to the capillaries. And oftentimes we find these individual, or it looks almost like a pair of smooth muscle cells that have wrapped around the beginnings of the capillary bed. And so the idea is, if for some reason you want to go around the capillaries, let's say there's no need to take blood to the capillaries, then what can happen is these precapillary sphincters can close off. The smooth muscle can contract, and so the lumen goes, closes, and that diverts the blood into what's referred to as a meta-arteriole. Now, we didn't talk about this in the voiceovers, and it's not something you need to know about for the test, but as long as you're asking. And so this acts to shunt the blood around the capillary bed where you go from arteriole right to venule. And you might wonder, well, why would you ever want to do that? I'll give you an example in a goose, of all things, a Canada goose, or a duck. Have you ever seen ducks or geese standing on a frozen body of water? You all have, right?
Yeah.
Yep.
Yeah.
Yes.
You think their feet get cold? I don't know the answer to that, but I can only imagine it probably is, but they don't seem to be bothered by it a whole lot. Is there blood flow going to the webbed foot, do you think?
Yes.
Yeah, because if
gotta
you
be.
don't have blood flow to a tissue, what's going to happen to the tissue?
That is.
It's going to die, yeah. So I'm not suggesting we cut off blood flow to the webbed feet on the frozen lake, but what I'm suggesting is that we can shunt most of that blood away from the foot, give the webbed foot some blood, right, to keep it viable, but you don't want to be losing excess heat, and that's where the heat is in most animals, is in the blood. So there's arterial venous shunts that would circumvent the blood away from the areas that don't need it as much and conserve it into the core of the body, for example. So there's an example of where those precapillary sphincters can sometimes come in handy.
Okay.
And then, of course, as I said a few moments ago, once we have that gas exchange, nutrient waste product exchange going on, and when that's finished, then we take that blood back to the venule, which merges into larger diameter veins, and then eventually back to the heart.
Okay. So the main reason for the precapillary sphincters are kind of like a
To basically regulate blood flow,
when needed.
around or through the capillaries. Here's another example. If you have a big meal and you focus on the capillary beds, let's say, in the small intestine area where you're absorbing nutrients, or where you're digesting, we'll say digesting your food. You're absorbing nutrients there too. Have you ever noticed after a meal like Thanksgiving, let's say, you have this big wonderful meal, and then the afternoon comes and everybody's like ready to fall asleep.
Mm-hmm.
And if you were to compare the blood flow to your digestive tract, digestive system before you went to grandma's house versus an hour or two after she made that wonderful meal for you, I suspect there'd be more blood flow going to the digestive system after having the meal than prior to that time, because you don't need to direct as much blood to the digestive system because you have no food to digest, at 10 o'clock. Well, at 1 o'clock you do, because you just had a meal at noon. So think of, that's another example you could think of maybe.
Okay, so they're not usually they're not utilized on not daily basis, but like continually. It's more like when something else is stressed. It's like based off a stimulus.
It depends upon where the capillary beds are and what they're doing.
Okay.
I'm not saying this couldn't happen regularly in your body, depending upon where we're talking. It's not only occurring during a stressor time or anything like that. It depends upon what the needs of the tissue are.
Okay.
If you're running a race, for example, you want to have those smooth muscle cells fully relaxed so that you can divert as much blood to the muscle. Let's say that this muscle tissue here, right?
Yeah.
Let's take less blood to the digestive system. We don't need to digest our food. We're running a race. We need to devote the blood and the glucose to make the ATP. We need to deliver all that to the muscles and absorb that CO2. So in that case, yes, precapillary sphincters in the digestive tract contracted, closed off, those feeding skeletal muscle, relaxed, maximum blood flow.
Okay.
Yeah.
That makes sense.
Yeah, a lot of it's just intuitively kind of makes sense if you think about it.
Mm-hmm.
So they just regulate blood flow. That's what they do. And a lot of that is determined by the nervous system, because the nervous system often stimulates the muscle, or it can lessen the number of impulses going there, and so the muscle would respond by not contracting. It would relax, and that's described here in this exercise, chapter 2. Not only do we have smooth muscle, of course, here as noted by the precapillary sphincters, but if you go back, you'll see that the artery has a very thick wall of smooth muscle here, right? The tunica media is mostly smooth muscle and some elastic tissue. And then when you look at a vein, which is a little bit later, there it is, the smooth muscle is not as extensive, but nonetheless there is smooth muscle here. So you can also regulate blood flow in blood vessels too. So if this smooth muscle is stimulated to contract, what's going to happen to the lumen, the size of the space through which the blood is passing?
It's going to shrink.
Yeah, it's going to get smaller. We're going to have constriction. What's that going to do to blood pressure in that blood vessel? If we have constriction or contraction of the smooth muscle and the lumen is smaller, is that going to increase or decrease blood pressure?
Increase.
That's going to increase it, right? If this relaxes, that's going to decrease blood pressure. Yeah. And that's what I just finished talking about in today's voiceover, was regulation of blood pressure. So you'll be hearing about that.
Okay.
Yeah, this is good. This is the kind of questions that I'd like to have you ask me. Any other topics that you want to talk about?
No.
I have some questions, but they don't really have to do with the cardiac. They kind of have to do more with the blood. I thought of them while I was studying last week.
Okay, let's go to that.
Okay. One of them was, when you get a nosebleed, where is that blood clot coming from, and could it become an embolus?
Well, when you get a nosebleed, I'm assuming it's the blood vessels that are in the nasal cavity that for whatever reason have ruptured. Maybe it's due to very dry air. Did we talk about nosebleeds recently?
Yeah, a little bit.
Yeah.
We were talking to do with the nasal conchae.
Yeah, it seems as though oftentimes kids are more predisposed to nosebleeds than adults. Not to say you couldn't have one, of course, as an adult, but I can remember as a kid having them much more frequently than I ever have as an adult. And so I can't speak to exactly the cause, but I've heard kind of anecdotally if it's a very, very dry environment, let's say, that can somehow impact blood vessels and increase their likelihood of tearing or rupturing. So when you get a nosebleed, what's the first thing that you do other than freak out because there's blood all over you? Is maybe I can remember tilting my head back. You guys remember that? And then the other thing that I think what they tell you to do is to apply pressure, right? Or if it's a cut on your hand, usually you just apply some pressure. That seems to help in the stoppage of the bleeding, the hemostasis. And you're right, Michaela, I think you can certainly have a blood clot form if it's a significant blood vessel that, say, tore for whatever reason. But I've never really ever heard of wandering blood clots from a nosebleed. I'm not saying it couldn't have that, but I don't know. I'm not sure I'm answering your question.
Yeah, no, that makes sense. I didn't think they could become embolus, but I don't know, it was just a thought that popped in my head.
Yeah.
And yeah.
I think anytime you have a clot forming, although this would be sort of an exterior event, even though it's in your nose, it's not like it occurred in an organ or in the blood vessels that are delivering blood to your stomach or whatever. Now that obviously is an internal situation, which might be a little more risky, I would think, than if it was an external thing. But if you had a very significant injury externally, and this, you had a compound fracture, the bone sticking out of your arm or whatever, not to get gross, but it happens. You're going to have much more significant tissue damage. You're going to have much more significant coagulation and clotting. Then I would think you may have to be more mindful of that. But I don't know for sure.
Okay. And then I had another question. On Monday, you guys were going over angioplasties and the placing of the metal stents. And I was wondering if do they ever move? And if they did, since they're made of metal, would they be able to cut through the tissue and create like a huge problem, or does that not really happen very often?
Yeah, that doesn't really happen. Once they expand the stent, expand the balloon, and then the stent, of course, expands with the balloon, it's designed to really kind of embed itself in the tissue, so it's not going to slide down an inch or two from where you put it. So no, I've never ever heard of a stent dislodging from where you placed it. I've even heard of restenting procedures where you put a stent over a stent. So no, I've never heard of them moving, and I've not ever heard of them. You maybe envision a jagged metal piece that could cause damage to the wall of the blood vessel and cause issues, but I don't believe that occurs.
Okay.
Great questions, though. I have not researched this, so I can't speak for certain, but I've never heard of that.
Okay.
So yeah, I mean, we can talk about the blood chapter, or other questions, other chapters for that matter too. Obviously, you're focusing on cardiovascular and lymphatic for the fourth test.
we have the quiz next week and the extra credit paper, and then the week following the practical and the exam. That's it.
Yeah.
It's crazy to think that we're almost done already.
Yes. Yeah. And I, of course, sent you guys an email just sort of outlining those three things so that you knew. I didn't put the extra credit paper thing in there, but the quiz, the practical, and the exam. Right? You got that?
Yeah.
Yeah. Okay. So, right. I mean, after today, there's only 3 more classes. Monday and Wednesday, and then the following Monday. Yeah. And then hopefully we see each other come fall. I hope.
Hopefully.
Yeah. No guarantees though.
Yeah.
There's some schools apparently have already said that they're going to go remote in the fall. That was
Oh, really?
Yeah. I think that's a little premature, but well.
Yeah.
Okay. If there's no questions, I guess we'll break a little early today. Anything you want to ask?
I think so.
I do have a question about the essay. Do you have like, I was just wondering about the like title page, how that's supposed to be. Is it supposed to be just like the title and your name, our name, and all that stuff on the first page, and then like the actual essay starts on the second page altogether?
Yeah, I think that's what I would do, Melissa. I would just have that cover sheet be the title at the top, and then probably like quadruple space or triple space at least, and then your name, and then like another quadruple or triple space, and maybe the date, and then at the very bottom or somewhere toward the center bottom, bio 2510, anatomy and physiology 1, just the basic information that someone would like to know. Who wrote it, what's the date, what's the title, and what class is it? And then on that second page is where you'd actually begin. Yeah, and then the other thing too that I would suggest is the very last page or 2 be devoted exclusively to the bibliography or list of works cited. Yeah, that kind of bookends the whole report title page and the bibliography.
So you do want it in APA format then?
You can do either APA or MLA, whatever you're most comfortable with.
And I think we talked about it previously, but you want it double space 12 times New Roman?
I think that's what I said, yeah.
Okay.
Yeah.
Is the 6 page a minimum 6 page or just however much information you can get?
Let's see if I even specified. I know we probably talked about this.
I asked on the Facebook group and you had responded on there, so I just wasn't sure.
Yeah. So there's nothing in the syllabus that talks about space requirements. And so I would say excluding the cover sheet, the title page, and the bibliography, yeah, that's where the minimum of 6 fully typewritten pages would come in. Now, some of these topics you could go on and on and on for 15, 20 plus pages probably. I don't want to read that much. I don't have time to read 15, 20 page papers, and also microbiology report of the unknowns, and I've got a lot of things I'm working on that last week as well. So I would say minimum of 6, maximum of 8 or 9. I don't cut yourself short, but don't go on too long.
Okay, thanks.
Mm-hmm. Any other questions on the extra credit paper? Or?
So the bibliography will be sufficient for the articles, like the information.
What do you mean?
Because like we've talked about it before, but I don't know, for whatever reason I'm not like grasping the concept. I just want to send you what you want. But in the syllabus it says like that you wanted like hard copies of like the articles, et cetera, et cetera.
Oh, yeah. When you said articles, I thought you were, yeah, all right. What I was hoping when I wrote that was, and if it's really, really difficult for you to provide that, then let me know. But the idea here was for me to look at any sources you used. I don't need the whole entire, let's say you used a chapter out of a medical dictionary or a medical book or something to talk about the heart, something about the heart. I don't want that whole chapter photocopied. I would just ask for the page that you pulled that information from, and that's what you would include.
Okay.
And you highlight that part of that page that you directly used, or that you subphrased, or use the information held in that paragraph and put that in your own words, incorporated it into the paper. I just want to make sure you're giving proper credit and not plagiarizing. Does that make sense?
I think so, yeah.
I don't want you to go to a ton of botheration and work. That's not the purpose of that. So how many sources do you have approximately?
I'm in between all sorts of sources, but I guess I'm just trying to figure out like what I need to give you from them.
Okay.
But that makes sense. You explained that well.
If you have, I don't know, well, give me a source that you're using.
Well, I've been using sources from like Gale and stuff like that.
Okay.
So they're not typically like long, like chapters, like they're just like an article.
Sure.
So do you want a whole article then, as long as it's not like 5 pages, just like some of them are just like a page long kind of thing?
Yeah, that's all.
Yeah, okay.
That's all. I don't want the entire chapter. No, I mean, that's a lot of work for you to be scanning and saving and all. No, that's not the purpose.
Okay.
If you can provide a page from that source that you used, just so that I can see how you're doing it, that's fine.
Okay.
Okay, anything else?
It's kind of off topic, but you and I had talked through email. Do you still want to wait and talk about the course scheduling thing?
Sure.
Okay.
Yeah. Okay, going once, going twice. Last chance for questions. Okay, I will see you guys next Monday then.
All right.
All right.
Have a good weekend. Are you going walleye fishing?
No. Yeah, I know it opens Saturday, right? Is it?
I think so.
Saturday?
Yeah.
Yeah, no, I don't. I want to get out bass fishing actually on Lake Erie. It's a function of finding a good day. You know, it's been so terrible, windy and everything.
Yeah.
So
Absolutely.
I think we're getting some nicer weather, so hopefully soon.
Mm-hmm.
Yeah. Are you?
Oh, I think we're supposed to be.
You don't sound like you want to go.
We're fishing fanatics. That's all we do here.
Oh.
School and fish.
Oh, that's good. Well, I hope you catch something if you go.
Yeah, hopefully.
Yeah. Brad, take some pictures. Send them to me.
Okay, for sure.
All right. See you later.
Have a good weekend.
Thanks. You too.
Bye.
Bye. Okay, Melissa. So when would you like to get together to make out your schedule? We could, let's see. Have you looked at classes at all or anything yet?
And actually, I need to look and see. I remember, like, before this semester started, we had, like, looked at a paper of everything I needed to have. Because, like,